All right, everyone, it's noon, so we are going to start. We like to start these things on time. In case you're just joining us, please know that we are using WebEx events, so you will not see a mute button near your name. Please rest assured you are muted, and only the panelists will be able to unmute themselves during this presentation. That way we can have a good presentation for everyone. A couple of other housekeeping items before we get started. Please use the chat box to ask questions. You can ask questions at any time during the presentation, but please know we will be probably answering some of those questions, so we will wait to answer all of the questions once we conclude with the presentation. Once again, for those of you who might not know, my name is Kara Kumari. I'm Assistant Commissioner for Communications and External Affairs for DIDD. I'm joined by several people, including Jordan Allen, Deputy Commissioner for Program Operations for DIDD, and Patty Killingsworth, Assistant Commissioner and Chief of Long-Term Services and Supports for the Division of TennCare. And we are going to start off by hearing from my boss and our leader, DIDD Commissioner Brad Turner, with some words before we start this presentation.
Thanks, Kara, and good afternoon, everyone. I hope you had a productive week so far, and happy Friday to everyone on the call. Thank you for taking just a few minutes out of your busy schedule to join us. This is something that we're certainly very excited about and are very encouraged about the feedback and the input that we've received so far. And I want to make sure that I continue to drive that home, how this is a partnership and this is an engagement that we're looking forward to very much with you as you contribute feedback and share input and help us really see our blind spots. Because we want to make sure that this system delivers for everyone all across the state of Tennessee. And I think most of you know, our focus is moving in the direction that really focuses on a high quality of life, whether that's community engagement, employment, whatever that looks like. That's what we're wanting to build here. And I can't do this and we can't do this without you partnering with us at a very high level and providing support, encouragement, and moving the ball forward for all of Tennessee as it relates to people with disabilities. And I think that's what I'm really most excited about, is this an opportunity for us to continue to be a nationwide leader in what we're building in a program that's going to deliver the goods to everybody. And at the end of the day, that's really what we want to do here. And so we always want to continue to maintain a very open line of communication for questions and for concerns, for dialogue, and for anything that you see that we might need to know. We want to know about that. We're still very early in this process right now, but I'm grateful for Patty and her team and TennCare and the engagement and the partnership that we have with them. That's a very unified front as we move this forward, and you're going to be a part of that, both as providers and as stakeholders. This is something that we want you to be proud of and be invested in. And we're continuing to make sure that we're listening above all else as we create a system that's going to deliver for thousands of Tennesseans all across the state. And I'm just really excited about what it's going to look like. But as we go through this today, I want you to continue to take notes, continue to think of things that you can ask us about, to challenge us on, to make sure that we're working on this together. Because at the end of the day, the bottom line, I think, for all of us are the person supported in Tennessee receiving the best care that they deserve and creating an environment to allow them to live the types of lives that they've envisioned for themselves. And we can't do that if we're pulling the wagon in a different direction and that people have different motives about why we're trying to do this. I want you to know that at the core, for all of us that are involved with the state, it's around building a system that allows people to live the types of lives that they wanted to live, same as you and I would do for ourselves and for our children and grandchildren. So as we begin the discussion, be encouraged with where we are, be encouraged about the direction that we're going, and be very open and honest with us about what you're seeing so we can make sure that we make the right types of adaptations where we need to. But at the end of the day, we cross the finish line together as we deliver a world-class system for Tennesseans. So with that, I'll turn it back to Kara. Thanks, everyone.
Okay, thank you very much, Commissioner Turner. And by now, you should be seeing my presentation and our introduction slide for this presentation. We're going to start by going through the presentation, and then we have extended the time period for this from 1 hour to 1.5 hours to leave some time to make sure that people have ample time to ask questions after we're done. Also, as a reminder, we are recording this, so if you are unable to watch or you know someone who was unable to watch, we will be putting the link and the recording of this on our IDD integration page. Finally, one other note I want to mention. This, as we start to go through this presentation, this is going to be a high-level overview, and we understand that some of the terms in it may not be understandable to everyone who's on this call. What I would like to tell you is that we are going to be doing a family-focused presentation, one that will really focus on what families and people supported are interested in knowing on October 13th at noon Central. So we would invite families who are, of course, welcome to hear what we have to say now, but also to attend that presentation, because we want to make sure that we're presenting this information so that everybody is able to have the feedback, input, and understanding that they deserve as we move forward on this. So with that, I'm going to start the presentation. Over the course of the next 30 minutes or so, we're going to look at these things in the presentation. First, we're going to take an overview of the document, what this overview document really is. We'll talk about the steps we've taken so far as IDD integration goes. We're going to talk about the key objectives. What are we really trying to do here? And then we'll get into some of the different areas that we've broken down in this overview document, including the delivery system and contract structure, the program structure and benefits, support coordination, network management, value-based reimbursement, and then we'll talk about the next steps in the integration process and what we're hoping to get from you all as well. So why did we put out this overview document? When we released it last week, we wanted really to help stakeholders understand what the bigger picture is here, because I know a lot of people over the course of the past 3 months or so have heard, oh, there's 1115 waivers, there's 1915C waivers, there's going to be things that happen to the state plan, and then there are going to be things that happen outside of this. What we wanted to do was really share with you all what this process is going to look like and what our vision is as we move forward. So we put this document together to talk about the proposed changes that will be a part of that 1115 waiver renewal. We'll also talk about some of those proposed changes we're going to need to make to the Section 1915C waivers. These are the waivers that are currently administered by DIDD, the statewide waiver, the CAC waiver, and the self-determination waiver. We'll talk about the proposed state plan amendment, and then it also talks about the operational plan and the processes we're looking to develop as we move forward in this. Another thing is we really wanted people to know where we're going with this. One of the things we got when we collected stakeholder feedback was a real desire for really understanding where we are every step of the way. And we thought that this document is an important way that we show that we're where we are, how we want to be transparent moving forward, and where we seek additional input. And that's where we get to the last bullet, which is to really gather that additional input regarding these proposed changes. Because we, as Commissioner just said, you all help us be our blind spots and help us see our blind spots. So we really would like that input as we move forward with this process. When we talk about the steps we've taken so far, we're really talking about not only what we've done since July 8th when we first announced this, but really talking about what we've done for years prior to that. And the first would be on July 8th, we developed and released that concept paper. And that was really based on years of feedback we gathered from many different sources. DIDD has met with providers and people supported and our advocates over the course of many years. In addition, we've worked with TennCare on the State Transformation Leadership Group and also their Workforce Challenges group to really identify those things that matter, not only the drivers in the system, but how we problem solve one of the greatest issues facing our service delivery system these days, which is that DSP crisis. We developed and released that concept paper. Then we developed materials and held presentations for stakeholders. It was really important when we put together the concept paper that we also really made sure that folks had an opportunity for us to ask questions and hold those presentations. One of the first things, the feedback we got was really that some folks had difficulty understanding how families and how people supported would be impacted, how their loved one would be impacted. So we worked with the Tennessee Council on Developmental Disabilities to develop a more person and family friendly presentation to have for that family focused presentation. They are wonderful folks and great partners with us in making sure that we're looking at plain language documents as we move forward. And also we conducted targeted discussions with advocacy groups, with providers, and with People First of Tennessee to make sure that we were including all voices in this concept paper and the feedback that we collected after that. As I mentioned, we did have an online forum for feedback. And then when we got some comments about needing some more time after that family-focused presentation, we extended that time frame to the end of August. Once we got all of that feedback, which was hundreds of people, hundreds of pages of feedback, we had more than 100 submissions from family, providers, MCOs, advocacy groups. We really used that feedback to develop this more detailed overview document. So you may have noticed in the overview document, if you've read it, that we have a little chart that kind of talks about the different steps that will get us to program implementation. And you can see that red arrow where we are now. We're on the develop proposed plan and that gather input place where that red arrow is currently pointed. And you'll see the steps we'll need to take after that to really get us to that, that program implementation. And then really after that to make some modifications. During the initial, after the concept paper, we talked about how we gathered some feedback using the online forum, using question and answer sessions during the presentations, and that we got more than 100 folks who provided us with that feedback. That feedback was really targeted in several areas. We got a wide range of feedback, but really there were some real themes that we saw when it came to that feedback. It included feedback about services and supports and the importance of, in some cases, the continuation of care, and also where we might look to adjust services and supports to become more person-centered. There was a lot of input about support coordination and what the future of that should look like. Something we've heard a lot over the past 4 years since Employment and Community First Choices started, and even now, we received a lot of feedback about the alignment of administrative processes. That whole idea that we do not want to do that, folks should not need to do 4 similar things in 4 different systems. And really, how can we look to align some of those things and ease that burden? We heard a lot about the importance of DSPs. And as I mentioned, this is one of the greatest challenges we face in the IDD service delivery system here in Tennessee and also across the country. So we heard a lot about how important it was to people to have not only a quantity of DSPs, really the feedback was more about the quality of the DSP and how important it was to have a well-trained DSP and provide opportunities for their growth as well. And finally, we heard a lot about communication right now in this process, and also communication in the future. And how do we directly communicate with the people we support in a managed care system? This information on this slide is not new, but we thought it was really important to go over again. And that is, what are those goals that we have for IDD integration? So the first, and you've heard this a lot, but we always really want to stress, what are we really trying to do here? We are looking to create a single, seamless, person-centered service of delivery for people with IDD. That's the #1 thing we are trying to do, is to really make one system that works for all people with intellectual and developmental disabilities. We want to leverage DIDD's expertise and commitment and ensure those best practices across all of those different systems, not only just those that are currently under DIDD oversight. We want to leverage person-centered planning and a technology-first approach. That way we can use those things about what the person wants and how a person wants to be independent, and also use that technology to really support that independence, really develop employment goals, and also assist with the development of natural supports for people with intellectual and developmental disabilities. One of the ways that we will help achieve those outcomes is by using value-based reimbursement, so that we're driving that delivery system reward, that we're paying for the outcomes that we all want to see, and really rewarding providers for delivering those high-value outcomes. We want to align systems and requirements, like I mentioned, so that we're reducing duplicative processes and administrative burden for providers. The less time they have to spend on doing the same thing over in 4 systems, the more time they have to really focus on what we all want folks to focus on, which is supporting the independence and community goals of the people we support. We'll better utilize limited staffing resources. We've already talked a little bit about that. We do not have an endless quantity of DSPs, and really we need to make sure that we're using those DSPs where they absolutely must be used. We want to utilize increased efficiencies across IDD program budgets to serve more people off the waiting list. less administrative burden, ensuring that services and supports are being used as efficiently as possible. That will help us serve more people, especially now during challenging budget times. And finally, taking advantage of the increased revenue opportunity, something we've talked about before through leveraging managed care for some of these waivers. This is something that is necessary and has really already is helping us prevent cuts that would have been necessary during this public health crisis, and significant cuts that could have had an impact on people's services and supports as they currently receive them now. So those are the system goals. And now we'll talk about that overarching goal and approach. And this is really important, and that's why we've highlighted it, because at its core, these amendments are about continued system transformation and creating that single, seamless, person-centered system of service delivery for people with IDD that empowers full citizenship, ultimately achieving culture transformation. And this is important. What we want to know is that system transformation is not a moment in time. This is not a snap of the fingers and that on July 1, everything is going to be transformed. We understand that transformation takes time and that this is going to be a process that is going to take many different steps to accomplish. And what we're trying to do here is let you all know that these proposed amendments give us the authority and provide us with the options to make these changes that we really feel are necessary to continue to drive this system forward and really truly get out from what our past was as an institution-based system, and really into what our future is, which is a system of full community membership for people with intellectual and developmental disabilities. One of the ways we do that is through what we call the pillars of transformation. And I have to give credit to this pillars of transformation document to our former Director of Employment and Day Services, Jeremy Norton-Paul, because when we all talked about the big picture of what this looked like, he was able to say, really, this is what it is. Thinking of a house, what are the things at the foundation of the house? What are the things upon what everything else is built? There are two things, really, that workforce development angle. Do we have the quality staff to provide the services and supports that we need? And are we doing the things we need to do to train them, to promote them, to advance them, and to really make sure that they understand the big picture for people with disabilities? Also, when we talk about that big picture, we're talking about organizational culture and commitment. Are the agencies, not only DIDD as a state agency and TennCare as that Medicaid agency, but are the agencies that we've contracted to provide services, do they have that culture and commitment to providing services that allow for full community membership? So then we have those as the foundation. And when we start to build that house, there are three strong beams, I suppose. You know, they always say if you remove one beam and you don't put something in there, the whole house is going to fall. Those real pillars there are employment first. Are people supported, having the opportunity to receive that competitive integrated employment? And are we doing the things to ensure that people have opportunities to understand what a job in the community looks like? So employment first, technology first. Where can we use enabling technology so that a person can become more independent? What is it always necessary that a person be that support person? One of the things we've seen with enabling technology is so many people had opportunities to live independently, whether independently was all by themselves in their own home, as it was for some, or whether it was the ability that they could stay home for an hour or two without having staff and have that time to themselves. So that technology first approach. Where can technology really be used to increase that independence? And then that third pillar, and a very important pillar, person-centered thinking, planning, and practices. We can't only say that we're person-centered. We have to make sure that that person-centered mindset is involved in every step of planning for a person's services and how we go about implementing that person's services. So that's the third pillar. All of those are kind of tied together by that value-based provision of waiver services. So that's where we talk about that value-based reimbursement, making sure that we're rewarding the outcomes we want to see. That will also lead to that independence, and then finally that high quality of life, the quality of life that the people we support really deserve. And another thing we want to talk about is that this pillars of transformation, and when we talk about system integration, we are talking about a goal for all. And we're not talking about just moving the needle forward for a few people in the system, or, oh, only those who have the ability to live independently. We're talking about moving this system forward and not leaving anyone behind, even those who have more significant disabilities, complex medical needs, significant co-occurring behavioral disorders. Those people who might have challenges finding their place in the community, we believe that this vision that we're moving forward is one for everyone to experience employment and for everyone to experience community living. And this also includes those who right now are still waiting for services. And it's important to note that the proposed amendments are about ensuring equal access to services through the responsible and effective management of limited resources. And when we say that, we're not saying we're going to cut a bunch of people's services and give those services to another. We're not talking about a Robin Hood situation here. What we're talking about is really making sure that the services and supports that we're providing are individualized and matched to what the person's real needs are, and where possible, being able to empower folks to have more independence, rely on less paid support where appropriate, and really, really have that community membership and a life of self-determination. So we've talked a lot about these overarching goals. So let's take a look now at what we're talking about in this overview document about where we think we need to go to get there. First of all, when we talk about the delivery system and contract structure, right now what we're looking at is that long-term services and supports, or as we call it a lot of time, LTSS, will be administered through a person's assigned managed care organization. So everyone currently who is receiving services in the 1915C waivers or the Employment and Community First Choices waiver or an ICF IID already has an MCO. Now what we're saying is that in the case of the 1915C waivers and those ICF services, that LTSS benefit will also be managed through that MCO. So as we talk about, it includes those two waivers I mentioned and the ICF IIDs. We mentioned also that everyone also has MCOs in these programs. Many of them, like I said, for ECF choices, LTSS is already being managed through the MCO. Currently, 1915Cs and ICF IIDs, they have an MCO for physical and behavioral services. What will be different, and what will also be different for those who are in the Employment and Community First Choices program is that DIDD will lead and oversee the LTSS for all of these programs. And it's important to note, because we've gotten a lot of questions about this, is that at the onset, these payments to MCOs for this long-term services and supports will not be fully risk-based, but will include incentives to align with the achievement of those individual and program goals. So we are not looking at risk-based payments initially. You may recognize this document, this graphic from our overview document, but this really kind of visually shows what we're looking at when we're talking about the contract structure. Obviously, CMS is still the federal authority to approve and oversee all of federal Medicaid programs, and then TennCare is the arm that really has that state plan responsibility for Medicaid programs. Through that, TennCare currently has and will continue to have an interagency agreement for DIDD. This agreement will make DIDD the operating agency for LTSS when it comes to the oversight of those. TennCare also has contractor risk agreements with the MCOs, so that is how they work together. And finally, and this will be a new thing, DIDD and the MCOs will establish an IDD program operations agreement, which will better dictate how DIDD and the MCOs work together in the provision of this LTSS. When we're talking about system transformation, we're going to be demonstrating how managed care can help achieve improvements in support system and culture transformation. First of all, we're looking to preserve, protect, and strengthen core system values. Finally, we are going to, and we've talked already a lot about this, we want to align incentives in a way that will support the achievement of individual and system goals. One of the things we really want to do is bring to bear the tools and capacities that experienced health insurance companies have to coordinate and improve healthcare and outcomes for those, especially those with complex medical needs. One of the things we've talked about is by having the MCO involved in that LTSS, it really helps connect those physical and behavioral health benefits as well to that LTSS to make sure that all three of those different types of services are talking to each other and coordinated for a whole person approach. We want to, like we've talked about, reduce that administrative burden for providers and help them develop the capacity to deliver the high quality supports and produce high quality outcomes. And when they do, we will pay them more. Provide a direct leadership and oversight role for state IDD agencies. So DIDD to be able to provide that expertise that we have and that years of knowledge we have to make sure that the person is being put first and receiving the services and supports that are truly allowing them to meet those employment and community living goals. So how do we do that? What does that structure look like? First of all, and this is very, very important, and this is very much something we heard a lot of feedback on in that initial round. We are going to be maintaining the 3 separate programs on July 1, 2021. So if you are still in the statewide CAC and SD waiver, you will remain in those waivers. If you are in the Employment and Community First Choices program, you will still be in the ECF Choices program. And finally, you will maintain that ICF IID program as well. The benefit structure is going to largely stay the same. We are not eliminating any benefits. However, and we'll talk about this a little bit more in just a second, we are combining that residential and many of the day services, we're combining that benefit really to drive more flexibility. And we'll begin to evolve certain benefits to better align with program goals. It's important to us when we talk about program goals, we really want to leverage that person-centered planning, making sure that planning, practices, and thinking are all aligned and all embedded in our system. We're going to leverage the employment-informed choice process, something that has been done very successfully in the ECF Choices program, enabling technology, not only providing assessments, but also looking at reimbursement, telehealth, value-based payment, and other approaches to advance achievement of person-centered goals, including employment independence and community living. We will be maintaining consumer direction in the SD waiver, and we're also going to be adding it to the statewide and CAC waivers. And it's important that we will not be making any changes to expenditure caps in any of the programs. When we talk about program benefits, we'll go through some of the different things that we're talking about here. First of all, therapy, behavior, and nutrition services. And it's important to note that we are, and you will see this on several slides, we are going to be seeking feedback and input on some of the strategies, but we are looking to continue to ensure that therapy, behavior, and nutrition needs are met in all of the programs. What we want to do and what we plan to do is move towards a consultative model currently used in the Employment and Community First Choices program. And what does that look like? What that means is that licensed professionals will teach, train, and support paid and unpaid caregivers to embed treatment in the day-to-day delivery of supports. It's important to talk about that when we're talking about some of these important therapy services, folks, you know, it's not only about whether or not a person receives 1 hour of services 1 day a week. Those strategies and those things that are helping to improve that person's health and well-being really should be embedded in their day-to-day life to make sure that we're always trying to help move that person forward, and it's not just relying on a scheduled appointment. Nursing services. We will continue to ensure that skilled nursing needs are met. That is something we heard about in the feedback. We really, however, want to better utilize skilled nurses, and here's why. We've talked already about workforce challenges and the DSP crisis. we're in, and so is the entire nation, in the same situation with nurses. We do not have an infinite pool of nurses to pick from. So what we need to do is really target where we're using our skilled nursing. What we need is for skilled nurses to be providing and performing those most complex skilled nursing tasks. What we also need is for nurses to be able to teach, train, and support caregivers to perform those more routine tasks, such as blood sugar checks or nebulizer treatments, many of the things that we might perform on ourselves at our homes. Finally, we're going to use telehealth consultation or remote support as needed. We've already seen a lot of success with this through the Station MD model, and we believe that we are going to see more success as we move towards this model. And then, like I mentioned in the previous slide, we, of course, will always be looking for input as we continue to move forward down this path, and input and feedback on these strategies. So residential and day services. Currently, in the 1915C waivers, residential and day services are billed separately. And most folks who are 1915C waiver providers know that well. And what we've ended up doing is really kind of artificially saying, okay, at this point of the day, this is a residential service, but at this point in the day, you have to bill this as a different type of service. What we found is that that's really limiting. And even when we tried to offer more flexibility through the revision of our employment and day services, we found new limitations. So what we're trying to do here is make sure that we are providing that true flexibility to allow people to engage in their communities and have the employment in the ways that they want to. And the way we're going to do that is by combining that 1915C residential and most day services into a single benefit called community-based living supports. The payments for these services will be combined into more modernized and flexible individualized benefit driven by the needs and preferences of a person. It's important to note that while we're talking about one benefit, all of the day service options will continue to be available. And people will receive the supports they need to achieve individualized outcomes and participate in the activities they want to choose. So it will no longer be, it really will provide that flexibility that we've been looking for this entire time and that we've been aiming to have all the time when it comes to where they can do their day services or their services, how, what time, when, how long. Of course, these settings will always be in effect and will always need to be conformed with, but we are really hoping that this provides the flexibility that we've all been looking for when it comes to how people spend their days in their communities and how they live their lives at home. Important to note that employment services will still be reimbursed separately, and that includes job coaching. Now we'll move to the next part of program structure, and this is going to be ICF IID services. And what we say when we mean that is intermediate care facilities for individuals with intellectual disabilities. These services will continue to be covered, but starting on July 1, 2021, new admissions to an ICF IID will be limited to persons with such significant co-occurring behavioral challenges or complex medical needs that the person cannot immediately be served in a more integrated setting. And then we're going to be looking to do that for a limited period of time while it's necessary for us to complete a comprehensive assessment of their community living needs, develop a comprehensive transition plan, identify a community provider, and seamlessly transition to a more integrated community setting. So what we're talking about here are really those shorter term placements where we can transition into a more integrated setting where appropriate. This will align the provision of this benefit with the integration mandate of the Americans with Disability Act, and the community informed choice process will also be required prior to admission. So how are we going to do that? How are we going to look at new admissions? These decisions are going to be made by an interagency review committee, and that will be led by IDD with membership from both TennCare and the MCOs. This interagency review committee is a process that has already been used successfully for employment and community first choices and some other areas, including groups 7 and 8, and for homebound services in the 1915C waivers. And it has been a very successful model, and we expect it to be a very successful model here as well. So when we're talking about going forward, no earlier than July 1, 2022. So no earlier than that July 1, 2022 benefit, individualized review process will be commenced so that we can identify people who are currently receiving ICFIID services as of that July 1 date who can be supported in a more integrated community setting. So what are we talking about here? First, we're going to be leveraging the community informed choice process. And we'll be working with each person who chooses to transition to develop a really individualized comprehensive assessment to make sure that we're developing a plan to seamlessly integrate them and identify a community provider and transition them into a more integrated setting. TennCare and DIDD will work with ICFIID providers to repurpose bed capacity so that it can primarily meet that transitional stabilization assessment and planning needs of those who have those significant co-occurring conditions, as well as those who have complex medical needs. And the ICFIID reimbursement methodology will be restructured to reflect the higher acuity of folks who are receiving these services and also to reflect the value-based incentives for specific outcomes that lead to integrated community living. So that's what we've got when we're talking about the program benefits and the structure. Now we're going to move into another area we heard a lot of feedback about, and that is support coordination. So one of the things we heard a lot from the feedback is that currently people like their support coordination model. So those current models of support coordination will be kept within their existing programs. Those people who are currently in the statewide and CAC waivers will be keeping their independent support coordinator. Those who are in the SD waiver will continue to have a DIDD case manager, and those who are in the Employment and Community First Choices program will keep an MCO support coordinator. It's important to note, though, that just because people will be keeping that support coordination model, we do not want support coordination necessarily to look the same way it does today. What we want to do is we want to make sure that these models are effective, that they are really driving the person towards meeting their goals, and that we are really making sure that we're measuring how these models are helping people get there. So we will review their effectiveness with regards to supporting people to make those person-centered life choices, where we'll be seeing utilization of enabling technology to increase their independence and achieve their employment and community living goals. One of the ways we'll do that is by using value-based reimbursement. That will be for ISC services, and also there will be value-based payments for MCO support coordination. So value-based reimbursement will be an important part of support coordination going forward. Another thing that we're going to be doing right now, we call it something different in every program, but in the 1915C program right now, it's called the level of need. What we'll be looking at is really a level of support, and that will be determined by what's called the supports intensity scale, otherwise known as the SIS. Important to note that this is an objective assessment that measures each individual support needs. It's currently being used in 20 states, including here in Tennessee. So the SIS is not something that is completely new to the IDD service delivery system in Tennessee. We will be taking this SIS and coupling it with another thing that we are also currently using in the 1915C waivers, and that's going to be an enabling technology plan questionnaire, really identifying those opportunities. How can technology help increase independence, not only inside a home? Because when we talk about enabling technology, we're not just talking about remote supports. What we're talking about is looking inside a home. We're looking at multiple settings. How can enabling technology help a person at their home? How can they use it to work independently, potentially without a job coach? How can they use it to travel independently? We also have seen great success on utilizing enabling technology on public transportation. And how can they use it to engage with their communities? Also, we will be working towards an aligned person-centered support plan across all programs. And when we say PCSP, it's called an ISP in the 1915Cs. It's called a PCSP in the Employment and Community First Choices program. What we're looking to do is have an aligned PCSP across all programs that really is driving the system forward and driving people to meet their goals. When we talk about what supports, how supports will be requested and approved, DIDD will have oversight, but the MCOs will be reviewing and approving person-centered support plans, and that includes those service requests. DIDD, like I mentioned, will oversee that MCO service approval process, And there will be certain criteria developed that will trigger a DIDD review of those service approvals to make sure that the services are appropriate and that any denials or service reductions are appropriate as well. In addition, DIDD will lead a coordinated approach to quality monitoring and improvement for person-centered plans and planning processes. We have an amazing person-centered planning team, and the expertise that they bring to the table is something that can be leveraged across all programs, and we're very excited about the opportunity to be able to do so. As always, input is welcome on these criteria. Where should that criteria for what triggers a DIDD review? We would love to hear from you on that, or any of the processes or things you want us to know about ISPs or person-centered support plans that you feel are important we know as we look to align that and to have a single plan. We've talked about support coordination. Now we're going to talk about provider network management. And like I said, we've talked about this a lot. Currently, if a provider is in all three waivers, in the employment and community, is in all three waivers, the 1915C waivers, is contracted with all three MCOs in the Employment and Community First Choices program, and is also an ICF IID provider, there are 5 different processes for enrollment and credentialing of those providers. And oftentimes, there's a lot of overlap. Feedback, one thing we got a ton of feedback is a strong desire to streamline these provider credentialing processes. So what is this going to look like in the future? In the future, DIDD will serve in the credentialing role for all IDD HCBS providers. So it's important to note, though, that all providers that are currently credentialed and contracted in ECF choices, the 1915Cs and ICF IIDs, would be deemed as credentialed. And those new providers would be credentialed on the standards based on that Pillars of Transformation document that I showed you at the beginning. Important to note, though, that the MCOs have the ability to build their own networks, and they will not be obligated to contract with all deemed providers. In addition, there will be the development of preferred standards for providers. And after at least 12 months, some preferred standards will become required standards. And those standards will be increasing over time. So providers will have the opportunity to achieve the expectations. It's also important to note that DIDD can require the MCOs to contract with a highly preferred provider to fill service gaps or address any quality concerns. So DIDD can still require MCOs to contract with a highly preferred provider. But saying all that, I also want to talk about continuity of care. On July 1, 2021, people in the 1915C will keep their current ISP as we work towards developing a single person-centered support plan. They'll keep their services and they'll keep their providers. And those MCOs will be obligated to contract with all 1915C providers deemed by DIDD for at least the first 6 months or the remainder of the ISP year. We want to be able to give folks time to be able to understand the new standards and be able to meet the new standards. And we are expecting that all providers will want to do that. But if they don't, this will allow for transition planning if that current provider is no longer able to meet those standards and is no longer part of an MCO's network. We will have ample time to be able to transition people into a provider who can help meet their goals and achieve their outcomes. Another part of provider network management is authorizations and billing. We got a lot of strong feedback here also, which indicated the desire for a streamlined billing process. And we share that desire as well. And so we are exploring a consolidated billing and authorization system. One thing I said earlier was that systems transformation is not a snap of your fingers point in time. And a lot of these things will take time for us to implement, explore, and make sure it's done the correct way. And so for July 1st, we will likely not have a consolidated billing and authorization system ready. So current billing processes will not change for 1915C and ICF providers, and those payments will be made by the MCOs. Now we'll talk a little bit about value-based reimbursement and the feedback that we are excited to start gathering from our group of providers. The goal here is really to align payment with individual and system outcomes, to pay for the goals and outcomes that will help drive the system forward, rewarding providers for value and driving delivery system improvements. Some of the proposed components of an approach were shared in that overview document. So if you have not seen that yet, there are some examples of what that might look like. Important to note that we're once again going back to those pillars of transformation. We believe very strongly in the pillars of transformation, and that this value-based reimbursement domains, they will be aligned with those pillars of transportation. And then they'll include two different types of metrics. Capacity building, what are providers and others doing to really build that capacity for change? And then also, are they delivering those outcomes? So there will be metrics based on both of those. Those capacity building measures and alignment of value-based purchasing and credentialing standards will be able to position providers for success. As I mentioned, it's very important for us to hear feedback on this. And one of the ways we wanted to do this was by gathering a provider work group called Partners in Innovation. They're going to assist in the development of our value-based approach. And these are providers who are already experienced in many of the things we're talking about here: employment first philosophy, embracing and enabling technology, and really providing a high level of services to folks across IDD service delivery system. And yes, that does include those who have significant behavioral needs and also complex medical needs. This value-based reimbursement approach will not likely be ready by July 1, 2021. Like I said, we're not talking about snapping our fingers here. We are really looking to make changes and make those changes incrementally as needed to be able to have that time for feedback, review, and really make sure that we're achieving the outcomes we would like to achieve. Also, this will require incremental changes, like I mentioned, to ensure stability for persons supported and providers. Once again, we are looking to do things in a way that is incremental and does not disrupt network stability, or more importantly, stability for the people we support in all three service models. So that is our overview of where we are going and what we are going to do. Here are the next steps. First of all, feedback. We want to hear from you, and we're going to talk about this next round of provider feedback, which will be a little bit more targeted. We will be establishing the Partners in Innovation work group and other work groups around areas of focus. That includes support coordination, communication, clinical services, some of those areas where we've heard that there is a desire to make some improvement. Develop proposed amendments. We will develop these proposed amendments, and they will go through that amendment process, and the process that we always have for all proposed amendments. And then we'll implement the program. Once we have implemented the program, I would love to say that 100% of the time we get 100% of the things exactly the way they need to be. But we understand that sometimes when you implement, you see places where you need to make modifications, and we will make those program modifications as well if necessary. We put this in bold because I cannot underscore this enough. Input is critical at every step. We want to hear from you. And now we're going to talk about this round of input. First of all, we want to understand your perspective. So first, like in the last round of input, we will ask you, are you a person supported, a family member, or a provider? Then we'll ask you to select the specific section of the document you're commenting on. There's going to be a drop-down box, and you will see the drop-down box. There will be the different sections of the overview document. And in the case of a program structure, if you comment on that section, there will be a subheader for either nursing services or therapy services or ICFIID services so that we can break it down even further. We'd also like you to select the page of the material you're commenting on so that it can help drive us to where we need to be looking. And then we want to know, are you expressing a concern? Are you asking a question? Or are you sharing a recommendation? That way we can really make sure that we're developing a comprehensive list of FAQs. We're really making sure that we're identifying those concerns and then working towards looking at all of the recommendations. As always, please be as specific as you can. Right now, the form stack will be going live in the next day or so, possibly on Monday. But I have left. We have 10 different boxes for 10 different questions, sections, concerns, whatever. If you need more than that, go ahead and fill out another form. If you don't need all 10 boxes, you just need 3, go ahead and just fill out those 3, and then you can press the submit form at the very end. So we just wanted to leave you all ample space to be able to provide your thoughts and concerns. And with that, I am done talking, and I'm probably going to need to take a big sip of my tea because I feel like I've been talking for a while. I will stop sharing my screen. We have Jordan and Patty on here to discuss questions, and we've got about 40 minutes for questions. So I'm going to start at the top, and we'll get going. Will all on the call receive a copy of today's presentation? We will be putting this presentation on our IDD integration page, and in a little while, I'll pull that up and show you all where that is. And you can see some of the stuff that's on there as well. We are also recording this so that people can, and we will be putting the recording of this on so people can go back and revisit if they would like. Tara keeps referencing 4 systems. Could someone explain what the 4 systems are? When I say 4 systems, what I really meant was the 1915C waiver. 4 systems are the 1915C waivers and DIDD oversight, and then each individual MCO's requirements for their LTSS for the Employment and Community First Choices program. So when I was talking about 4 systems, that's what I actually meant. Will there be another opportunity for online feedback? Yes, Russ, we will have that posted shortly, and then we'll share that information with everyone. But that link will go live eventually on our IDD integration page. Will the changes with nursing services be the same for ICF services as well? Patty, would you like to address this question?
Sure. The ICF services are really driven by the federal requirements, and they're a part of that benefit. So the things that we're talking about changing with respect to nursing will not impact how nursing needs are met in the ICF IID benefit.
Okay, is there a yearly cap for therapies? Sorry, I'm scrolling down. Is there a yearly cap for all therapies? Choices documents say 5,000 yearly, perhaps 10,000 if justified. Will that be similar for DIDD integration? Patty?
So what we're talking about so far is that we want to evolve these benefits more toward a consultative kind of a model. We have not said that we intend to place any specific limits beyond those that are currently in place around assessments and visits and things like that. But we have asked for feedback around potential approaches to really getting to the place we want to go. We've talked about potential changes in the scope of benefits. We've talked about potential changes in the use of telehealth or value-based reimbursement. So we really haven't decided exactly how we're going to evolve that benefit. It is an area in which we are seeking input.
Thanks, Patty. I'm going to ask Jordan to take the next question. Does this revamp of ICFs mean that no one will be placed there long term? Jordan. Hey, Jordan, unmute, please.
Sorry about that. Can you hear me? Yeah.
I gotcha.
Thanks, and good afternoon, everybody. So first and foremost, we are not saying that people won't remain in ICF services for the length of time that they need to be there. I think that what we're saying and the construct of the idea around reshaping ICF supports and benefits is based on the fact that we want to ensure that people that are receiving an ICF benefit need that model of service and don't have the ability or can't be better supported in more integrated settings. Certainly, as ICF, the model of ICF services has evolved over the years, really decades, so too has the community-based or HCBS waiver system. And the truth of it is today, and the providers on the phone and the families and the people supported in ICF settings will understand this well, that services that are provided now in integrated settings, medical residential services, for instance, even some supported living services, with the appropriate clinical supports in place are certainly have adapted and have evolved to the extent that they can provide those kind of supports. People that previously were in large institutions and moved into community settings, at the time that they moved, the ICF model was as closely linked to the institutional model of services as we get through the continuum of support. Since that time, we certainly have developed the ability for people that even have very severe medical needs, and certainly some folks that have co-occurring diagnosis are being supported very well in integrated settings. There are people that are now achieving degrees of control and independence in their own lives in ways that probably were unfathomable even 5 years ago, certainly 10 years ago. So I don't think what we're saying is that people that really need that support won't be able to continue to receive that model of service. What we want to do is ensure that everybody understands all the choices that are available, understands how those services can meet their needs, and then has the opportunity to be supported in as integrated setting as possible.
Okay. Will we be able to train the routine, non-complex healthcare tasks without an RN delegating his or her license? Patty, do you have a thoughts on that?
Yes. So there are current statutory authorities that allow us to utilize the self-direction of healthcare tasks that sit separate and apart from and really are exempt from, if you will, the Nurse Practice Act. So the short answer to that is yes, there is a pathway to be able to do this without delegation of nursing authority. Certainly we want to do it in the right way and make sure that appropriate training and oversight is provided to a person who is not a nurse who is performing those tasks. But we believe that there are many ways to do that. Families do these kinds of care all the time. And in most states, honestly, unskilled workers are allowed to perform these kinds of tasks with appropriate training and oversight.
Great, thanks, Patty. Will providers who are credentialed in the 1915C waivers and with all 3 MCOs but do not provide ICF services also be deemed credentialed? Jordan.
Sure. So again, the short answer to that is you do not need to be a provider of all 3 within the ECF program, within the 1915C waiver, and then also an ICF provider in order to be deemed during that initial 6-month period, and then certainly to apply for services in either of the waiver programs thereafter. So you don't have to be a provider of all 3 to be deemed.
Okay. Do therapists need to join the MCO to continue to provide therapy once the 6 months are completed? Patty, would you like to weigh in on this?
Sure. And so it's really before 6 months, right? So beginning July 1, all 1915C providers, all ICF IDD providers will need to have contract agreements with managed care organizations in order to continue to be paid for the services that you deliver. That will be important. And then going forward, you will need an agreement with the managed care organization to deliver those services.
Great, Patty, and I'm going to stay with you. Could the MCO decide to go with a bigger therapy group rather than some of us DIDD smaller group therapists?
It's a great question. I think we heard these same concerns back when we started the Employment and Community First Choices program. And this is one of the important points of the credentialing standards that we talked about in the document around really creating preferred contracting standards that help to make sure that we get the right providers who really have expertise in serving people with intellectual and developmental disabilities. Will health plans have flexibility to bring in additional providers? Sure, they will, but we'll create those preferred standards that really help to make sure that we're getting providers who have the right expertise and commitment, and importantly, can deliver the outcomes that we're looking for.
Thanks, Patty. I'm going to go to Jordan for the next one. If a provider is interested in being a part of the Partners in Innovation work group, how can we request to be a part of this group? Jordan?
Sure, thanks. So first and foremost, the Partners in Innovation work group, the initial selection process for that group involved provider agencies that are already, in some cases for up to 2 years, are already very active in participating in a lot of the pilot projects around enabling technology, and now even kind of foraying into integrated employment options utilizing technology. But probably as a foundational bedrock for that selection process, it was providers within our network that are already probably 1 foot, maybe both feet involved in really innovative and progressive programming ideas. And why we thought that was important for the initial selection was for us to be able to hear some of the successes that they've had. I mean, the department is wholly invested and has been for some time now in alternative and innovative solutions, but it's the provider community with whom we've shared that information and any available research that we've been able to attain through our pilot projects that have really taken that concept to the next level. And so we thought it was really important to bring those folks to the table here initially as we began to discuss the concepts or potential concepts that would be included in a new program design. Certainly, we've been very upfront about the fact that we want to make sure that these options, that enabling technology, some of the advancements that are so easily accessible, affordable, and available now, and the utilization of those products and services, the impact that they've had on people is well understood as we begin to kind of develop a construct around value-based payment incentives, and as we start to think about how we can actually fund and support utilization of those services all the way from the planning, the beginning of the planning document through the outcomes that ultimately end up the result of that planning process, and then the achievement of those outcomes. So the group that we've selected now will be the initial group. Where that group goes after our initial meeting or after our initial meetings, I think that group will help define that. So we've limited it at this point to 9 provider agencies, and what the future holds, I think largely will be the result of those first couple of meetings.
Excellent. Okay, and I am going to be adding really quickly 2 of our assistant commissioners as panelists for 2 of the next 2 questions. The first will be, what will the quality monitoring or assurance process look like in this new integrated system, and will this new system be implemented by 2021? I have added Pat Nichols, who is our assistant commissioner of quality management, as a panelist, and she might have some words to say. Pat, can you unmute? We're still not hearing you. Okay, we will skip down. Pat, we'll skip. We're going to come back to you. The next question we got is, are there any updates on the integrated reportable events management system? If Teresa, our general counsel, are you able to speak as well, or no?
If she can.
Oh, I figured it out. I'm proud of myself. That was harder than the bar to figure out how to unmute that. Patty, if you want to respond, that's fine.
No, that's great, Teresa. Go ahead. Thank you.
Kara, we are getting really close. We have the final drafts of the REM protocol as well as the definitions that are with leadership for final review and approval. We are confident that we will have the reportable event form within the focus system to go live for the implementation. We are working with Quilts to develop the training. We met last week with them, and we're just kind of tweaking some stuff that we've already drafted. We were going to use in another means, but we've decided quilts is the best option. We're actually excited after that first meeting about what this is going to look like and how this is going to work. So we're working on just kind of getting that ready and going forward. And we're also, as you know, Kara, trying to finalize the communication that's going to go out. So we're just moving along. Things have got stalled a few places, and we've had to kind of back up and make some changes as we operated within the COVID environment, and we could not do in-person trainings as early as we would have liked and things like that. But I mean, it's exciting. We're almost there. It's been a lot of work on the part of everyone involved. So really be excited when we can finally launch. Thanks, Kara.
All right, thanks. And I think that we are good to go with Pat. So on the quality assurance process, what will that look like, and will this be implemented by 2021? Pat, if you would like to weigh in on that.
Okay, I certainly will, and I'm so very sorry. I hope you can hear me now. Okay, it's a Friday afternoon, folks. I apologize. The short answer regarding the quality monitoring process is that there will be one quality monitoring process. We are just getting started looking at what that is going to look like, and so we will be working on that up to the time that it's implemented, I'm sure. We are looking at the ECF process that we're involved in, as well as our longstanding quality monitoring process. I know that the benchmarks or the foundational things for this process are going to be looking at outcomes and what they do for people, looking at the administration of programs and the organization, as well as how those programs impact the lives of individuals. I know that is a very broad 30,000-foot response, but at this point in time, that's where we are, and we'll be gathering input for the quality group, just as we've been discussing, having input for all of the other things that we're going to be looking at across the system. Kara?
Thank you very much, and thank you, Patty, for letting us bring these questions, the panelists add on you all. I appreciate you all for being so flexible and patient with me. Will it be possible to download today's PowerPoint from the DIDD website? Yes, all of our things, once we put them on there, should be able to be directly downloaded if you would like to do so. And we will get this up shortly after this presentation so that it can be viewed for folks. We already answered that question. Will facility-based services still be an option? Jordan, would you like to take this one?
Sure. So as we've mentioned previously, there's kind of two layers to it. So the first one is there won't be changes to the benefit structure in the 1915C program. So the services that are available within that program will continue to be available, and facility-based day services have never been available in the ECF program, and certainly won't be added by virtue of a single system alignment approach going forward. So FB Day services will continue to be available in the 1915C program.
Okay, the next question I'm going to go to Patty, and then Patty, I'll stay with you for the question after that. The first question is why isn't traditional choices included?
Great question. So Choices is a program for a different population, primarily for older adults and adults with physical disabilities, and not for people with intellectual and developmental disabilities. So there are a lot of areas where we are looking for alignment across the entirety of the system, reportable events management being a great example, where we really are looking to use the same definitions and the same process across all of our programs. But that won't be unilaterally true. I don't foresee a future probably where the Department of Intellectual and Developmental Disabilities is overseeing programs for older adults and adults with physical disabilities. I think we'll get to as much alignment as we can, but primarily what we're talking about today is really intellectual and developmental disabilities.
Great, and then Patty, I'm going to stay with you for the next question, which is there is an emphasis on MCOs will not be risk-based now. When is it vision that they will be at risk?
I think we don't know, right, if or when we would change the payment approach. What we know is that we couldn't do capitation or risk-based capitation payments now, especially given the fact that we'll be making some changes in the program that might not allow the historical expenditure data that we have to really be used for actuarially sound rates. It is something that we want to continue to explore going forward, and we don't have a timeline for that. We don't have a commitment that we absolutely ever will do capitation-based rates or that we won't, right? We really want to have that flexibility to continue to look at that going forward and decide what makes the most sense for people and for the program.
Excellent. Thank you very much. Jordan, I'm going to go to you for the next question is, if funding is delinked from staffing ratios, how will staffing levels be determined and how will you ensure everyone gets the staffing you need? Jordan, can you answer this question?
Sure, and it's a great question. And in fact, I think it really kind of draws out, again, one of the real foundational components about what we hope to achieve going forward. So first and foremost, understanding how our system works today, and then without getting into the history of the development of that system, in short, what we've done is build a system that assumes a recommended staffing ratio based on someone's determined level of need. And so what we've learned certainly over the years in programming and what we knew, I think, intuitively on the front end is that not everybody, even folks that seem to fall into similar categories, has the same need. And not everybody is the same person. The timing in which they need supports is different on a person-to-person basis, just like it is for any one of us. And so I think the intent with any new program design starts first and foremost from the perspective of building supports around people that they want and they need, and they've indicated to us, they and their family and the circle that participates in that process, that they need to achieve a greater level of independence or reach closer to their desired life. And so by setting artificial boundaries or staffing ratios around people and lumping folks into specific categories based on the assumption that their individual needs then disappear and are kind of absorbed into what we anticipate that group's need to be, what we've done over the years is really hold some folks back. And so we really want to kind of pull away at that thread. So to directly respond to your question, Russ, I think that our intent will be for people and their families to determine what it is they need to be successful, for provider agencies, support coordinators, therapy providers, those people that are providing the supports, then to put those supports in place around each person. And certainly at the point at which those supports aren't working, not unlike the way it is today, then we would expect adjustments to be made. But those decisions and those determinations, nobody is better equipped to make those determinations relative to staffing needs than the people who are directly providing support and the person supported and their family that surround them during those conversations. What we want to do is allow the availability and the flexibility of that group of people to determine how and when people receive direct staffing. Certainly, we're hoping, and in fact, we've seen that when given that opportunity and given that freedom, when we remove those artificial constructs, that people choose differently than those lanes that we put people in for the last 10, 15, 20 years. And so ultimately, it'll be people supported, their families and their circles that decide when and how much staff that they need.
Okay, will DIDD operated ICFs be a part of this integration? If so, how does that work? Patty, can you take this one?
Sure. The short answer is yes. We do intend that all ICF IID services are part of the integrated program. So the state-operated facilities will also contract with the managed care organizations. Second part of the question, how does that work, is really the same way that it works today, right? Which is if you think about how oversight processes of ICF-IID's work in today's environment. The Department of Health is the state survey agency. They contract with the department to survey private facilities, but not to survey their own facilities, right? The Department of Health continues to survey those state facilities, and that structure will continue going forward. And we, as the Medicaid agency, will continue to oversee the entirety of the ICF-IID benefits. So anything that the department might do from an oversight perspective with respect to the private facilities, TennCare would have those responsibilities as it relates to the state oversight role.
And Patty, I'm going to stay with you for the next one regarding nurse delegation and training non-skilled staff and performing routine care like blood sugar checks and nebulizer. Does that apply to ICF-IID as well?
We are only talking about self-direction of healthcare tasks, and the authority only exists for home and community-based services and not for institutional services.
Okay, thank you for that clarification. I'm going to stay with you on this one. Has a training curriculum already been identified with a launch date with quilts? As you all are aware, TennCare has led the efforts on quilts, and I'll go to Patty with that.
Sure. So maybe more information than folks want. Quilts is really a broad umbrella, right? It stands for Quality Improvement in Long-Term Services and Supports, and it encompasses all of our value-based purchasing initiatives in LTSS, as well as the work that we've done around workforce development. And a part of our work around workforce development is the development of competency-based training components to really support the workforce across long-term care programs. One of those is the 12-course curriculum that was designed for launch through the community colleges and technical schools that includes the award of a post-secondary certificate, 18 hours of college credit, kind of all of that. That was set to launch this fall, and then came COVID. The community colleges and technical schools had to turn their attention to converting all of their courses to online learning format, so they weren't able to actually launch the curriculum this fall. The other thing that happened is that we lost the previously approved funding that would have provided the direct workforce incentives to people upon completion of those modules. So that has pushed us back in terms of actually rolling that training program out. I will say that we're not letting that stop us, however. We've been working with the Department of Labor and Workforce Development to create a new registered apprenticeship program that will use much of that curriculum as a part of a registered apprenticeship program with the U.S. Department of Labor, allowing providers to sponsor individuals to come to work for them and participate in the training program, and continue, by the way, to receive the same workforce incentives that would be paid by that provider agency. Really important to understand, though, that's not the only training program that we've developed, that big 12-course curriculum. We've developed all of the training programs that we would use to prepare unskilled workers for self-direction of healthcare tasks. We've also developed some pre and early service learning that we think would be a big part of aligning training requirements across the HCBS programs for people with intellectual and developmental disabilities. So there's a lot of work there that has been done that we will implement in steps as we begin to move forward with this integration.
Thanks, Patty. And I apologize. I had been scrolling down to just kind of get an idea of how many questions there were based on time, and I skipped a bunch of questions. So I'm going to go back. So apologize to those who were waiting and thought their question was going to be next. Can you expound more on value-based reimbursement, especially dealing with support coordination? Jordan is going to talk about that one.
Thanks, Kara, and certainly I'll call on Patty here also. First and foremost, what I would say is that the concept of value-based payment reimbursement is certainly one that we are excited about exploring. We're light on response and details because we haven't really begun to flesh out those details. I will say that as it pertains to support coordination agencies, certainly We believe and understand that case managers, whether it be support coordinators, MCO case managers, or our own, are instrumental in, one, educating families and people supported about the services that are available, and really we need them to kind of be the spearhead, the leader of those discussions. So it's not just, here is the package of services that are available. What we need those folks to be doing is saying, here is the package of services that are available. I know you personally, and here are the things I think you might be interested in, and then let me tell you how these things work, or let me explain to you how you can move through kind of that continuum of support to get to where it is you've told me you want to go, utilizing these services. And so in order to do that, just like any of us, they need to understand it at an expert level. We really need case managers, and this isn't to insinuate that they aren't now, but there is so much, the availability of so many new options, approaches, and even pieces of tools of support are available now, that what we want to do is bring that expertise up to a level where those folks really are equipped to do their job and be the experts and be the leaders in those meetings that they can and should be. And so they'll be part of the value-based reimbursement structure. As long as we're expecting them to lead, then we need to reward them when success is achieved. So they certainly will be part of that structure going forward.
Okay, thank you very much, Jordan. MCOs have not contracted with single-person agencies. How will they be able to continue in business going forward? Jordan, do you have, or Patty, do you either of you have something about this?
Patty, you want to take that one?
Sorry, if I take myself off mute, I can. So if for existing single-person agencies, we will, for purposes of continuity of care, we're going to continue those contracts with single-person agencies, and the health plans will contract with them. We won't be contracting with any new ones, but we do want to ensure continuity for people who already have those single-person agencies in place.
Thanks a lot, Patty. The next two questions are both about the Partners in Innovation Group. What about including other stakeholders like persons affected, family members, and ISCs in the group? And will you share who the providers are in that group? Jordan, do you want to talk about this?
Sure. I'm trying to read them, and I don't have my readers, including, oh, okay. Yeah, so as I mentioned before, first and foremost, we are including ISC representation in the original selection. So we do have ISCs in that group now, including people supported and family members. First and foremost, absolutely, we will be including input into the topics that we're discussing with the Partners in Innovation Group, whether or not we expand that group or fraction off into specific affected stakeholder segments or regions. We're just not sure what direction that's going to go yet, other than to understand that we wanted to bring together a group of folks across our system right now who are very effectively supporting people, doing so in a very progressive and innovative way, and hear their experiences and ideas. What I would say is that the opinions, the input, and certainly at the root of all those discussions are people affected, and certainly their family members as people who sit and help them plan and decide what their outcomes are. They're represented in every word we speak, every discussion we have, every piece of stakeholder feedback we pull back in is all with the design and intent to meet the needs that they've stated to us. So whether specific membership will break off to include that spectrum, I can't say. I would anticipate that it might, but I can certainly ensure everybody that it's their desires and the communication that we receive from them that derive the agenda and topics. As far as the providers that are on that group, again, I can tell you right now that we've solicited involvement from 8 providers, and we have an ISC provider also in that group. Until we've received confirmation from the entirety of that group, we're not going to release the members of it, but I anticipate that we'll receive confirmation here shortly, and then certainly we don't mind sharing.
you very much, Jordan. Next question. Could an innovation group of providers be assembled for the development of the singular QA process so providers have involvement in review of the QA process? Pat, if you don't mind me putting you on the spot again, QA is your area of expertise.
You know, I like being on the spot every once in a while. I think that this is important for us to get feedback from anyone who wants to give us feedback. And I think some opportunities for that have been presented to you all this afternoon in terms of how we're going to take the next round of feedback. I think that would be an excellent way to start, giving us your feedback regarding the quality portion of this plan. So let's get started that way, and we'll see where we are then, and we'll be able to have to assess what we need to do going forward after that. I do feel there's probably a group in our future, though. Kara?
Awesome. Thank you very much, Pat. We have 2 more questions, and it's good because we only have 5 more minutes. Can we anticipate that the early and pre-service training for the 1915 waivers and ECFs will be consolidated by July 2021? Jordan or Patty, either of you want to talk about this?
Solid maybe.
Yeah, I'll say I sure hope so. That's how I was going to respond. Yeah, I think we're intending. Go ahead.
No, that's fine. Handle. You do it.
Yeah, I think that our intent is to move. There's so many things, so many processes moving at once right now, and as much as we would like to be able to divide and conquer everything at once, we just can't. I can tell you that from our perspective, that's where we're tracking. We want a single menu of services. Of training. We want that training to be indicative of the value and knowledge that we want DSPs to have across this system. And so there's going to be some change even in the things that we're expecting them to learn and know. Whether we can get it done by 7/1, I don't know. Patty?
I would agree with that. I think a lot of the content is content that we've now developed, and we have to figure out the right, we have to figure out the alignment pieces, and then the right timing for being able to roll that out. And there are lots of things for us to consider in that process.
And then, you know, honestly, with some of these questions, both Jordan and Patty have so much expertise, I could flip a coin. So since we're talking about training, I'll flip this one over to Jordan. Will the department be using one system, and will be training combined instead of one set of training for ECF and another for DIDD? And will the system be reliable?
The answer to that first question is yes. Eventually, that's where we want to get. The answer to the second question is we haven't determined yet. We have to finish the first before we can get to the second.
Okay, and so that is all of the questions that I've seen in the chat box. And it is 1:27, so we have come up to our time. But before I left, I wanted to direct you all to the IDD integration page on the DIDD website and the things that you can see there. First of all, once we make live again the IDD integration input, it will be found you can click and submit see the form by pressing this button. Currently, that takes you to nowhere, but it will take you somewhere soon. In addition, we've got all of the letters, the concept paper, the letters we've announced, the frequently asked questions, the former recordings of the WebExes for folks, the stakeholder input summary, and all of the overview document and everything else. We've also started to break things down into the family letters and the different presentations we've done. So I just wanted people to see what we have available already on the site so that people know where they can find things. This would be the overview document right here. We will continue to add to this site so that we can continue to make these resources available to you. And we encourage everyone to go there and look, and also let me know if you are looking for something, and maybe I can help you on that. Carly has shared the direct link to that site in the chat box as well. So it is 1:29, which means we are 1 minute away from 1:30. I want to thank Commissioner Turner and then Jordan and Patty for taking some time with us today to go through this. We had a lot of really good questions, and I hope you all found this useful. We hope to continue to offer these opportunities along every step of the process so that we can really continue to have these conversations with you all and facilitate answering the questions that are out there. We want you to hear directly from us, and we hope that we can continue to do that. We're committed to doing it, and we look forward to our next conversation. Please, if you join us on office hours and you have questions, feel free to use that as a venue to continue to ask questions. And with that, we'll see you all later. Thank you guys very, very much for joining us today.
Thanks.